Thank you very much. Well, now we've got two loud mics, so we'll see. We'll see how that goes. Okay, it's very good to be with you. There's no group of healthcare leaders that I would rather be spending this time with for reasons that I think will become apparent in this talk. I want to just sort of acknowledge that this is at least there are three biopsychosocial reasons why this could be challenging for very different reasons. One is that, as evidenced by events down the street last night, our national family system is a little screwed up and conflicted right now to a point where that becomes distressing. So factor number one. Factor number two is that this, as I've observed, this collaborative and intense conversation or series of conversations that you have at this meeting is engrossing. And so many may be filled up, almost all filled up with ideas and sort of ready to check out, which makes it hard to concentrate, especially on something that is as challenging. And a third reason why this may be challenging is that a number of us have lost friends or have lost people in our care. And there is almost no other health-related event that is more hurtful than this one. So that's a third challenge that some of us are experiencing. So I want to just offer an invitation, if you're interested, to close your eyes and take a cleansing breath. Okay, and then we'll proceed. So this is a picture, you can't see the lines, but you don't really need to, of the death rates for four major causes of death over the last 15 years or so. The two lines that trend down mildly are the overall death rate in the United States and the death rate for heart disease, which as the number one cause of death obviously is pretty closely correlated. The two at the bottom are death rates for cancer and stroke. The line at the top is the death rate for suicide. And one of the things this illustrates to me is that you can achieve some progress when you pay attention to it. And we're paying far more attention to cancer and stroke and heart disease. Although if we paid attention in more fundamental ways, if we paid more attention to family systems wellness and to addressing adverse childhood experiences and so on, we would see that line for cardiac illness shift quite dramatically. But just as it is, these trend lines show the level of attention to these issues as opposed to the level of attention to suicide and suicide prevention. I want to give you a little bit of a background of what's been going on in the suicide prevention field recently, because it kind of leads up to this idea that beginning to focus on suicide in healthcare settings is an important and heretofore a missing ingredient in our focus on this issue. There have been several major strategies in the last 20 years to promote wellness through primary prevention, that is so-called upstream preventive activities, which in this arena, as in those others that I mentioned, is surely the most fundamental way to make change. But it's also exceptionally hard to gear up and to get to scale. I'll just illustrate that in one way. The only national suicide prevention program we have is focused on young people aged 10 to 24. It's under the Garrett Lee Smith Memorial Act. Garrett Lee Smith was the son of then Oregon Senator Gordon Smith, who took his life as a senior in college, and his father took this cause to the U.S. Senate and was able to get legislation passed. But because of the demands and constraints of politics, it's well less than a $100 million program that focuses only on youth. So there's been a lot of focus on youth, a lot of energy on on high schools and so on. But to illustrate the challenges, if we take the concept of the number needed to treat, that is the number of people who we would have to treat to prevent an adverse outcome with respect to youth suicide, we'd have to work intensively in about 40 high schools to prevent one death of a young person by suicide. So these efforts in a capitalist democracy to bring a public health perspective to bear are quite challenging. A second effective means to reduce suicide would be restriction of the means by which people die. This is demonstrated through lots of research to be very effective. For example, an experience in the Israeli military where they discovered a high rate of suicide, and on probing deeper found that most of the deaths were on the weekend with the members' service weapon, and so they adopted a policy of leaving your weapon at the barracks when you go home for the weekend. That alone resulted in about a 40% reduction in deaths by suicide, as did other systematic efforts to reduce means like changing away from coal gas in England to forms of heating gas that were not so lethal, changes in fertilizer in India. So these are very powerful mechanisms, but if we just think about, on the one hand, the 50-year effort to get barriers put up on the Golden Gate Bridge, or if we just envision firearms restriction, the number one cause of death in the United States, we see that these are exceptionally hard to do on a broad scale. A third major strategy of the field over the last 20 years or so has to do with efforts to try to work with people that might be called gatekeepers, whether teachers or public health nurses or cops or so on, folks who come in contact with individuals, to encourage them to identify people that are suicidal and refer them to care. This has been the major strategy, probably, that grantees under this Garrett Lee Smith Act have carried out, and the evaluation shows that it's effective in the following way. That is, communities that have one of these grants that focus on educating people about youth suicide achieve a reduction in the youth suicide rate, but only the youth suicide rate, not the rate overall, and only as long as the grant activities are carried out. So this is also very hard to do. Now, this issue has been nagging at me and others for quite a long time. And so as a mental health director, this is always something I tried to work on. And so we were doing these activities that we were supposed to be doing. And I hadn't noticed much of an effect. And so it has led a number of us to begin to explore this issue of thinking about healthcare as a staging ground for both the identification and the treatment and support of people that are suicidal. So I'm going to tell this story a little bit, but start by illustrating the dynamics just a little bit more. So this is sort of the headlines that I'm going to go through in some more detail. Most people that die by suicide have been engaged in healthcare where we didn't identify this as a risk or we didn't do anything effective about it. It's like a hard way to put it, but that's sort of what the reality is. But suicide prevention hasn't really been a priority. We've had a national strategy for suicide prevention since 2000, year 2000. Again, one of the activities of Surgeon General David Satcher. But that national strategy did not have as a goal establishing this as a core responsibility of healthcare. And if we think about other areas where this might have been tagged, the only real national mandate, if you will, was the Joint Commission's 1996 establishment of deaths of people in hospitals as a sentinel event. That is a so-called never event, something that should never happen, but only in hospitals. There really been no standards or focus on this explicitly in outpatient mental health context, although it was clearly something that wasn't supposed to happen. Not much of an explicit focus, certainly even less in healthcare, even less among health plans. So there's not, actually that's not true. I know of one and possibly two health plans in the United States who measure death by suicide among their members, but nobody else does, and nobody tells them that they ought to. And this is, in effect, a conspiracy of silence. It has been a conspiracy of silence. But there's good news about this as well. One of those is that the tools to do the work are pretty effective. A challenge is almost all the tools that are effective, that I'm going to run through quickly, have only been developed and tested in the last 15 years, which means that nobody who's out there working was exposed to them, because a lot of us were trained before that. Or if we've been trained since then, we were trained by people who were trained back then and didn't get the memo about this as an issue. So, but the good news is the tools are now available, and they're almost all available free. And the challenge here is to speed up adoption of suicide-safe care in a healthcare system that, as you all know, in many cases better than I, is famously fragmented and part of the culture wars and distracted right now. And so I want to tell the story of how this journey has gotten to the place that we're at. It kind of starts in a way. There are two starts of the story of suicide prevention in healthcare. This is one of them, with this National Action Alliance on Suicide Prevention, which was launched in September 2010. This is a small public-private group, modestly supported by the federal government, that is supposed to sort of lead the charge for suicide prevention and also advise the government on ways to improve the strategy. Interestingly, the existence of the national strategy was one recommendation of that President's Commission back in 2003, not because of me, because one of our members was a survivor of her husband's suicide. She's Wally Prechter, he was Heinz Prechter. They were German immigrants who came to this country and settled in Detroit. Heinz was an engineer, and he invented the sunroof and established a company selling them to the American auto industry, made $1 gazillion, but what contributed to his success killed him. And that was that he lived with bipolar disorder for all of his adult life, which contributed in part to his insatiable energy, but the downs were, at the end, too much for him to take. And so Wally, his widow, was the leader on this cause among us. I'll mention one other obscure, except perhaps in this room, the recommendation of the President's Commission that took it more than a decade to get done, and that was the recommendation that collaborative care be explicitly reimbursed by Medicare. You know, who'd have thunk that that would have taken all the time that it's taken to get established. So some of us at the first meeting of that Action Alliance, sought permission to create a task force to focus on clinical care and intervention. Essentially, our challenge was to try to explore this unexamined sector of suicide prevention, or to put it differently, to explore the unexamined issue of suicide in clinical services. And much of what I'll describe emerges from there. And so I want to start by illustrating what are the patterns of suicide in relation to healthcare, and I'll start in the place that we've focused on for some time, which is inpatient care. Again, the Joint Commission put out its first Sentinel event in 1996. There's been a big focus on trying to reduce suicide in inpatient settings. By my estimation, only about 2% of all suicides occur in inpatient settings. So, yes, people in our care ought not to die when they're in 24/7 care under our attention. We did a little study of the patterns of suicide in New York and found that 83% of all the people that we could identify were people receiving community care. That is, these are people connected to the mental health system who died. The vast majority of them were in community care. 17% of the deaths we classified arbitrarily as being related to an inpatient episode, but almost all of these were post-discharge. And it's an interesting, it helps you look at the problem differently in a way to realize that within 72 hours of discharge, 4 times as many people had died by suicide as they were probably hospitalized as dangerous to themselves by reason of mental illness. And, strangely, 5 days in the hospital didn't fix that. And in our fragmented system, not much happened when they left. And one of the things that didn't happen that I'll come back to is nobody checked in. Our national standard is the HEDIS measure, for complete one visit within 7 days, which is an inadequate standard for people that are suicidal. And our national performance on that is worse, I believe, than any other HEDIS measure at about 51% in 2015. So it's not that inpatient care doesn't need some work, but that's not really where the problem is. A number of states now, this is just a sample of them, have crosswalked participation in their community mental health system with suicide death records, finding consistently that about 20% of all the people that are dying are people that are in care that should have been oriented to keeping them alive. So this is way disproportionate to the number of people who get community care, because it's like almost impossible to get in, but still it's where the highest risk is. But of more concern to healthcare leaders more generally, and CFHA members in particular, is to find out that there are many more deaths where there's a contact in the medical system, not the mental health system. So from a number of sources, about 45% of people who die by suicide had contact with primary care in the month before they died. And Yates Conwell at the University of Rochester says for older adults, that's 78%. So if you think about that, what are the odds that that's chance? It's near nil. So then what was going on? These are older people, mostly men, who had pain of some kind, probably didn't have a concept to articulate it, probably didn't have a readiness to articulate it, but were distressed enough to go see a trusted health practitioner. And what didn't happen? They weren't asked. And there are lots of reasons why we weren't asked. It's not really our job yet. What are we going to do if we find out the answer? We don't have enough time until we are practicing in a collaborative setting. It's almost impossible to do much about it in vanilla primary care, which is one of the reasons why I'm so delighted to be with all of you. And then we have this study in South Carolina that crosswalked ED visits with deaths by suicide, finding that 10% of all the deaths by suicide in that state were people that had been in an ED in the previous 2 months. Strangely, that didn't give them what they needed either. I mean, that's not very strange. So we have significant opportunities to raise the bar in our healthcare settings. And this is a kind of a simple-minded, safety analysis of how people fall through the cracks, which is one of the terms that's used all the time when somebody dies. They fell through the cracks. We use Swiss cheese here, and the holes in the Swiss cheese instead of the cracks, not because it's a Wisconsin thing particularly, but this guy James Reason, who's a safety analyst, focuses on this approach to safety. He says that for any one thing you do, it's going to be effective in large measure because it's designed to solve the problem, but there's still going to be holes in it. An easy example is if we decide we have a training gap and we do a training, the people who attended the training may have had their skills improved, but within 2 months there's going to be turnover and people who didn't get trained are going to be there. That's a hole that people can fall through. So this analysis of the cracks illustrates the problems that we have to fill. And what I'll turn to as soon as illustrating the problems is to show that there are now new resources specifically targeted to fill each of these holes. So the first question is the first question, and that is, do we ask people who have come to see us if they're having thoughts of suicide or self-harm? If they do, and in systems that have started to do suicide screening among everybody who comes in, and there aren't many, but there are a couple, it's like 4 to 5% of the population that have some significant risk on a screener. That number is higher than the number who have very high risk, because there are a lot of people who live with suicidality but are never going to take their life because they have very strong reasons for living. They may have learned to live with the voices of the dark thoughts. They may have developed skills to cope. But for many, that's not the case. And once we ask, we need to sit with people and to work on doing something about this in a fashion that starts with a relationship and starts with other relationships that can be helpful. And then to focus specifically on safety. I'll talk more about that in a second. If there's a standard of care for somebody that's explicitly suicidal who you encounter, the old and frankly ineffective standard of care is to send them to an inpatient psych unit. There is no evidence that in the long run that is helpful to people if you look at suicide rates. It's likely to keep them safe for a couple, 3 days, but as we've already said, the most dangerous day of their life is going to be the day they get out. So we now have much more responsive to ways to work with people. To reduce lethal means, not in the form of political kind of gun control, but in the form of something like, so you were thinking of ending your life, you have a weapon, you took it out, you may have put it to your head, you didn't do anything yet, but that's still there, right? Yes, that's still there. Would it be okay if we called home now and had that weapon put in a safe place until you feel better? That is lethal means restriction of a different sort that is eminently feasible and very effective. The fourth missing ingredient, or strength, if we really are cooking with gas, is to treat suicidality. Well, what do you mean, treat suicidality? I mean, treat the suicidality. The way this usually works is you get sent to the inpatient unit because you're dangerous to yourself. While you're there, does anybody directly work with you on the thoughts and feelings of self-harm? No. We kind of have this hope that if we medicate the depression for 4 days, that's going to get you through this. And you will, in 3 or 4 days, learn to say the magic words. Think of another healthcare condition, if you can, for which, when admitted to an inpatient unit, it doesn't get treated. I haven't had anybody name one yet in this regard. If you come up with one, let me know. So this is relevant now because in the last 15 years, we have 3 or 4 evidence-based therapies specific to treating suicidality that show effectiveness, not in terms of feel-good effectiveness, but show effectiveness in terms of reducing deaths and attempts. And finally, do we stay in touch? I gave the example of the poor performance on the HEDIS measure. It turns out that the single best researched, most effective thing to do with suicidal people is to reach out and touch them. And it's easy to understand in a way because suicide grows in isolation from one's family system, from one's community. And the evidence on reaching out, what's called supportive, non-judgmental contacts, but just reaching out and touching someone are very effective, and the evidence doesn't suggest there's any difference in effectiveness between a call, a letter, a text, an email, a chat, or a visit. Any one of those things turns out to be very effective in reducing suicide as well as reducing self-harm. So these are the holes in the system, but this also suggests what the solutions are. And so good suicide care essentially consists of taking these activities and building them into a care pathway, the same way we would build a care pathway for any other chronic and life-threatening health condition that somebody had. So I said before there were two places where this approach to suicide care was born. One of them was the recommendations of this clinical care task force. The other was that it turned out there was somebody who'd been doing this for 10 years by 2012. And this was the most effective suicide prevention program ever carried out in the world. But it actually wasn't a suicide prevention program. It was the Perfect Depression program at Henry Ford Health System in Detroit, which was launched about 2000, as you can see. As I said, it was not a suicide prevention program. This was an effort that leadership at Henry Ford put together in their behavioral health division in response to the Quality Chasm report. And in particular, a response to a solicitation, I think from RWJ, for health systems to propose an approach to try to achieve perfection in a particular sector of healthcare. So not surprisingly, nobody else took on behavioral health in this challenge, but these guys did. There were about 300 applicants for this. There were 12 finalists. The Henry Ford team was one of the 12 finalists. They weren't one of the 10 organizations to effectively to eventually get grants, but they set out to develop a program to achieve perfection in, they called it perfect depression care, which I think was just labeling. It was really for anybody in care in their mental health division. And this became a suicide prevention program in the following way. When they presented this to the RWJ review team, they were going through how they were going to try to achieve perfection on each of the 6 quality chasm aims, and they got to the one about outcomes. And the best that they've been able to come up with was that they were going to try to achieve reductions of at least 50% on Beck depression scale measures for all their patients receiving depression care. At which point, the guy leading the panel stopped and said to Ed Coffey, who was the psychiatrist in chief, "Dr. Coffey, can we go outside and talk for a minute?" I mean, like, you don't do this in these settings. So they went outside, and this guy says to Coffey, "I got to tell you, I love what you're proposing here. Nobody else has taken on behavioral health. We think the challenges there are as great as any other area in healthcare, and I am really impressed with most of what you're proposing. But I wanted to step outside to tell you the following. If you think that partial reduction in symptoms on a clinical scale is a measure of perfection, we'll go home now. We'll just stop the thing and go home. But if you think you can go a little deeper and have a more fundamental concept of what perfection would look like, we'll go back and finish the presentation and continue in this process." And so Dr. Coffey, to his credit, says, you know what, you're absolutely right. We weren't thinking about this deeply enough. So they go back and get in their quality circles and so on and start to talk about what would perfection look like. And it is in one of those sessions we've all been in with flip charts on the wall and everybody getting depressed and the answers seeming to elude us. And a nurse says, "Well, if our depression care was perfect, no one would die by suicide." At which point there's a very loud silence in the room, and a senior clinician says, excuse my French, "Bullshit." And there you have the feeling about this in our mental health world. Well, to make a long story short, they decide to establish having nobody die by suicide as a possibly impossible stretch goal of this effort. And that senior clinician shortly thereafter left the organization. So that's how this approach to systematic quality improvement became a suicide prevention program, and this is their results. So this is a measure of deaths per 100,000 among people receiving behavioral health care in that large system. So you see that they started at a very high level, which is kind of what the baseline is for suicide rates among people with serious mental illness. They very seldom achieve perfection. They did for 1 year in 2008, 2009, but they reduced the suicide rate among patients with active major mental health diagnoses essentially to the level of the general population during a time, parenthetically, when the suicide rate in Michigan, like the rest of the country, was rising. So this was the first indication that a systematic approach was necessary. So this led, as I said before, to a new goal of the National Strategy for Suicide Prevention, which was updated in 2012. I don't know what we were thinking in 2000 when we didn't say this, but we weren't thinking about this because we were thinking of an approach to suicide prevention that would kind of like be the analogy to an approach to heart disease that says, let's have campaigns to not smoke and eat healthier and do nothing else. That's sort of been what our approach is like. And in that condition, as well as this, having good EMS and crisis care and so on is pretty critical. So we have this new goal. And more recently, the Joint Commission has ameliorated its past sins by putting out this incredibly well done and thoughtful Sentinel event alert in March of this year, which you can find on their website and which you should take a look at for two reasons. One is you may be in a Joint Commission accredited organization and they may snoop around about this the next time they come. But the more fundamental reason is this, in my view, is a signal for how attention to this problem is going. When a mainstream organization like the Joint Commission establishes this and raises the bar this significantly, it's a sign to the rest of us that eventually we're going to get measured on this as well. I'm going to, in 2 slides, go a little bit deeper to what are the clinical tools that have been developed in the last 15 years, in case you're interested, although this is just an appetizer. And then I'm going to talk a little bit about where to get resources if you're interested, and then close. I list a website here that we built, www.zerosuicide.com, and essentially all the tools that I'm about to describe are available on that website. That's a very annoying transition, I apologize, but somehow, you know. So the first of these is we have to ask people. What the Joint Commission says in response to the somewhat equivocal, shall we say, guidance of the U.S. Preventive Services Task Force, those people who said bravely this year, we should ask about depression, after saying for a long time, if you have the resources lying around to treat it, then you should ask. So their advice on suicide prevention is somewhat equivocal, but what the Joint Commission says is you should know your patients well enough to know if they have risk factors, which might include a mental health diagnosis, substance use, a history of trauma, recent loss, psychosocial stressors. So if patients have any of that, then they are at elevated risk and they should be asked. There's a paper by Greg Simon at Group Health and his colleagues in 2014 where they looked at this empirically in the following way. They had responses from 77,000 people who had filled out a PHQ-9. And then they went back and looked at, for those that had elevated responses on question 9, which is the suicide question. In the last 2 weeks, have you had thoughts or what? I don't remember it specifically. What they found was a 6 to 10-fold increased risk of suicide for those people who said, yes, I'm thinking about this. You know, surprise, surprise. So we have to ask. And if we ask and if people say yes, then we have to go a little deeper to really understand their risk. One of the effective tools, certainly not the only one, is the Columbia Suicide Severity Rating Scale. There's an interesting story there too. This is a scale that was not originally developed for clinical use. It was developed in response to the brouhaha 10 or 15 years ago when the news came out that young people started on, I think it was Paxil, had an elevated risk. And that finding led the FDA to do 2 things, one of which was smart and one of which was stupid. You know, the stupid one was the black box warning, which served as a disincentive to prescribe antidepressants. So fewer people died because they'd just been put on an antidepressant, but more people died. The smart thing that they did was to say, wait a minute, if we're, among other things, in the business of conducting depression trials, maybe we should have some way to inquire about this risk for patients that are going into a depression trial. So they came to the team at Columbia to develop this scale, which turned out to be pretty sensitive and effective, and became mandated for depression trials, which raises the question of, well, like, could we use it in patient care? So it is publicly available. The second intervention is a brief psychosocial intervention. When I say brief, like 20, 25 minutes, developed by Barbara Stanley and Greg Brown, called the safety plan or safety planning. This has moved very rapidly into use, although not everybody is doing it well, which is another challenge. And it's almost driven out the old and completely ineffective practice of asking the patient to sign a no-harm contract, which if anybody is still doing, you should stop as soon as you go home, because it's ineffective and doesn't help you. I mean, it might help you feel a little better in the short term, but there's no evidence it has effectiveness, and that liabilities are associated with doing it. So the safety plan essentially engages the patient with these feelings of self-harm and essentially tries to give them some tools to do something else than go down that path when the thoughts occur. So if you start to feel that way, what are things that you could do? Who are people that you could call? What are activities that you could take to try to feel a little better? Includes something about means restriction. So thinking about the safety plan as a one-page document, which it is, the patient walks out with a one-page document, which is perhaps helpful, is one way to think about it. The other way to think about it is essentially a psychosocial intervention that helps create some distance between the suicidal impulse and acting on self-harm. I talked about brief supportive contacts. I don't think I have to spend any more time on that. Just the takeaway is that any method of supportive contact looks to be effective in reducing self-harm. So when should it be done? Well, it should be done if anytime a high-need patient misses a visit, it should be done. It should be done anytime they've been in an emergency room or come out of a psych unit, and it should be done within a couple days, not within 7 or 8 days. And then this last element of direct treatment of suicidality. So this goes certainly beyond our time here, but the direct interventions include dialectical behavior therapy, cognitive therapy focused on suicidality, so-called CTSP, cognitive therapy for suicide prevention, and an approach called CAMS, the collaborative assessment and management of suicidality. it shouldn't be surprising in a way that these turn out to be more effective because they've got specificity. They specifically target what the concern is, and so no surprise, they're more effective. It goes without saying, and this is, I just want to acknowledge this, that putting all this in place is like not a turnkey operation. This is kind of like starting from zero with respect to diabetes care, which I think is a good analogy, because this is the best way to think about suicidality is not as a mental illness or as a symptom of mental illness, but as a distinct co-occurring condition that should be addressed on its own terms. So, this means training, probably everybody. It means putting a screener in the workflow and in the EMR. It means, as people who have started to do this work have done, having a safety plan pop up in the EMR if there are positive results on the screener, so that you can't skip that task until you've completed it and with the patient and printed it out for the patient. So I just want to acknowledge that nothing good and hard is done easily. So a little bit about the resources to do the work if anybody is interested. And again, this is just a teaser. So we've built this website, www.zerosuicide.com. This is just a screenshot, although I wish there was the time to click around it on just a little bit. But essentially, everything is there that you need to do this work. If you look on the left-hand side where it says Get Involved, one easy thing there to do is to sign up for a listserv of people that are doing or thinking about this, which is a great source of, it's a way to get practical questions answered, like a screener for kids, or what's been your approach with this, much as your efforts, I'm sure, have. And if you click on the toolkit on the top right, there's too much of that old guy, but then you see this is the landing page for one of the 7 elements, which is training. And for each of these landing pages about one of the elements, you will see resources that include brochures, instruments, streaming video, courses. I'll just mention 4 of those that are really good, because these are all good places to take a look at or to have some of your colleagues explore. So one of the streaming video courses is Kelly Posner, the developer of the CSSRS, the Columbia scale, talking through how to do it. Another is Barbara Stanley, demonstrating safety planning. A third is Maddie Gould, who's a psychologist and a researcher, talking about follow-up care. And a fourth, which is maybe the best one to take a look at early on, is a course called CALM, Counseling on Access to Lethal Means, which is very accessible and useful. So lots of resources that exist. So, where we are on this journey is just beginning. As I said, our report was 2012. Here we are 4.5 years later, so we've only just begun. And I like to think about this as a slow idea. If you remember Atul Gawande's piece in the New Yorker about slow ideas and fast ideas in healthcare. And of course, as a surgeon, he picks 2 surgical examples to study, one of them being sedation during surgery, and the other being sterilization. And you can guess which one of those moved fast and which one moved slow. He says apparently there was one Scottish surgeon who resisted the drive for sedation because of a belief that pain was part of the experience. But thankfully, there wasn't too much of that. That moved very fast because sedation turns out to be pretty good for the medical team as well as for the patient. Sterilization is just good for the patient. Well, it might be good for the medical team too, but it's a lot of work. This is a classically slow idea. I guess these thoughts are kind of obvious. Where is this at the national level? It's growing and attracting significant attention, but it's not, we haven't hit the prime time yet, which is, again, one of the reasons why it's so good to talk to you. NIMH has got an announcement out for research into this approach. They've just given a first round of grants. They're going to accept they have just accepted a second round that they haven't reviewed yet. So we do need more data, and policy support is growing. For example, a mention in Hillary's mental health plan and some resources in the budget for 2017. But we are just at the beginning. After spending all these years trying to run these big systems, I have graduated to this incredibly delightful position of being able to work only on what I want to work on. So I'm on this one, as you can tell, for the years that I have left. And I would like it if it didn't take the usual 20 years to get from early attention to this issue to adoption in a critical mass of places. So it's a movement as well as a mission. I like to end with this slide as a nod to Sully Sullenberger, who it turns out, in addition to being a safety fanatic, and what an awesome movie that is. His thing at the end where somebody says to him, "You're a hero," and he said, "I was just doing my job." And the flight crew did their job, and the flight attendants did their job, and the passengers did their job, which was a great statement of this challenge as well. And it's particularly relevant because Sullenberger lost his father to suicide. So for him and for many others, we do this work. If anyone is interested in reaching out to me for follow-up or questions, because as usual, I've talked long enough, so there isn't any time for questions. That if you're interested in follow-up, this is how to reach me. It has been a genuine privilege and pleasure to be with you, because I so much appreciate the ideas that are at the heart, the ideas and the values that are at the heart of what you do. So thank you very much. I hope you have a good remainder of the conference. Thanks. Thank you.